So, two matters that arose before the break that I've had an opportunity to look at. You will recall right at the beginning of this oral presentation, I gave an example of a woman who received blood following having 650 millilitres of blood in her abdominal cavity, and you asked me some questions about measurements. I'm grateful for those behind who have said that 1 unit is 500 millilitres. So the fact that she was given 3 units of blood would amount to 1,500 millilitres in the context where the blood loss on that operation note says 650 millilitres.
Yes.
So the point you were making absolutely stands. Then the second point...
Well, I didn't think I made a point. I asked a question, but it was certainly in the back of my mind that there's a potential overcompensation.
Yes. Now, the second question you asked just before we broke was about a little more detail for a woman in relation to the Eileen Trust documentation, just reminding everybody this was a woman who had leukemia, who underwent chemotherapy in 1996. She was transfused with 112 units of platelets and diagnosed with HIV in 1997. I found this extract, which we're not able to put up, but I'll just read it to you, sir. And as part of the investigation, a consultant haematologist wrote this: the donor had completed medical screening satisfactorily and completed the usual declaration of good health and absence of risk activity. During the course of the investigation, archived samples from the donors contributing to the 112 units given to X during her treatment were retested, and all were negative on repeat HIV antibody screening. A donation was identified using a PCR technique which demonstrated HIV viral DNA, and this donation, and then the donation number is given, was also HIV P24 antigen positive. This case therefore represents a window period transmission. No other risk factors were identified. So, sir, not a complete answer to the specific question you asked about testing, but I think that gives a broader position of the information.
Well, I wondered if there had been proper testing, or, as it were, one that got through the net, or whether there was a window period example. And that appears, from what you've just said, to have been the latter, appears to have been the case.
Yes, sir.
Yes.
Now, the latter point of this presentation examines the nature of information and issues of consent in relation to procedures, and specifically the period before and after a transfusion was given. The available evidence suggests that almost all patients were not informed that there was a risk of bloodborne infection prior to or after receiving a transfusion. In the vast majority of cases received by the inquiry, there was no discussion about the risk of transfusions, even for patients who received frequent transfusions and were regularly seen in hospital. So the evidence we've seen, sir, does not suggest, for example, that those with sickle cell or thalassemia or leukemia had the risks explained to them in detail. Many witnesses in their evidence make the point that they did not connect their poor health following a transfusion to any infection, but it attributed it to their underlying condition, or that the symptoms of their underlying condition masked the symptoms of bloodborne infection. And so that's important because they therefore didn't go to the GP or seek medical attention in relation to an infection. A significant area of the evidence relates to examples of transfusions where there was no consent given or even an express statement that an individual did not want to receive blood. And I'm going to take you to an example of that. This is a statement from a mother of a child who received a blood transfusion when she was 5 years old in 1990 at the Charing Cross Hospital. Now, this little girl was admitted as part of a sickle cell crisis, and she was treated with oxygen and monitored for several days. The treating clinicians then asked the mother whether the child could have a blood transfusion. And the witness spoke to her family members, and crucially her sister, who was a Jehovah's Witness. Therefore, after this discussion, the mother decided that the outcome of the consideration was that no transfusion should be given, and therefore the mother communicated that to the treating clinicians. We just look at this witness statement, WITN 1823001. And if you can turn to paragraph 11, please. Next page. So what she says is that at no point was I ever informed of the potential risks of having a blood transfusion. It was mentioned to me as possible treatment for my daughter to help her improve faster, at which point I specifically told the doctors that I did not consent to her having one, and it was then done behind my back. So the woman describes in this statement being at work and then coming to the hospital and finding out that her daughter had received a blood transfusion against her wishes. Now, in the daughter's medical records, there is reference to an additional transfusion that took place in June 1991. The mother does not recall the details of that specific transfusion, but accepts in her statement that if it's in the records, then it's likely that there was a second transfusion that took place. When the daughter was around 14 years old, she started to develop yellowing of her eyes, and in June 2002, she collapsed and was admitted to Homerton Hospital, and it was at that stage that she received a diagnosis of hepatitis C. She was then referred to the Royal Free Hospital due to the fact that she developed ascites and chronic liver disease. The daughter sadly died in 2003, aged 17, and the cause of death was concluded to be liver failure. The statements received by the inquiry also draw on the communication of diagnoses, and so this is a theme that you've heard in oral evidence and written evidence to date. Within the presentation, we set out a number of examples of poor communications about diagnoses. Some witnesses are critical of the fact that they received their diagnoses in writing rather than on a face-to-face basis. And there are multiple examples of witnesses who only found out that they were infected because they had themselves donated blood. And there's a frequently expressed sentiment that they donated blood because they had benefited from receiving blood. So it's common for some bloodborne infections to be flagged as part of a blood donation, and in those circumstances, it's common for that notification to be in writing. Some witnesses highlight the potential difficulties of that approach, particularly people receiving a letter completely out of the blue with no preparation or warning. So some of the examples in the witness statements relate to opening a letter at a time of day when the phone lines in that letter are closed, so feeling like they've got no one to turn to for any access or support. Other individuals opening a letter at home when they're alone with no family members, or after a really difficult day at work. So there are various criticisms made in relation to the written approach. The inquiry to date has had a lot of evidence orally of examples of poor communication techniques involving individuals when counselled face to face. And the witnesses that have received transfusions describe insensitively put questioning about their sex life, about tattoos, about alcohol use, about drug use. And many witnesses describe that as a very negative process. Other individuals describe being told of their infections in busy wards by busy doctors without any proper confidentiality. Others describe being told by doctors where it's clear that the doctor thought that the patient already knew. So passing references, oh, that's because of your hepatitis, for example, when the individual is unaware that he or she was infected in the first place. There are also a number of examples where individuals were infected and not aware during the course of their lifetime. 2 examples in this category, sir. WITN 3323001, please. So this is a witness statement from an affected daughter, and in paragraph 3 she sets out her various medical experience, and that's important for important context for something she says later in the statement. If we can go to paragraph 5, please, Sully. So she describes that her mum was in hospital having been recently diagnosed with multiple myeloma and having receiving treatment for it. She required a blood transfusion due to her low haemoglobin levels. And then there's a discussion about how long she was likely to live for. Can you look at paragraph 6, please? This conversation took place in September 1996, at around the time Mum received the infected blood transfusion, yet she died only 8 months later in 1997. Can you look at paragraph 12, please, Sully? It says this: after my mum's funeral, my dad went to visit the northeast for a few days where he and Mum spent time together before they were married, to feel close to her again. It was during this time, 5 days after Mum's funeral, that it was disclosed to my sister and I that my mum had received blood infected with HIV. This devastating news was given to us by Mum's GP and other clinicians. Paragraph 13, please. When we were told it had been discovered that 2 other patients had become HIV positive through receiving blood transfusions from the same donor that my mum had, we were told that the lab still had samples of my mum's blood after her death. I'm unsure why this would be so, or if this was indeed true. And this blood had been tested, and it was confirmed that my mum was HIV positive. It was at this point in my dad's home that he shared with my mum that Dr. Martlew acknowledged that the person who was giving blood at Liverpool had not been screened properly by staff and would have been high risk. No further information was given to us. Neither doctor provided any information about the effect of the virus on my mum's illness and death. Thank you, you can take that down. Another example of communication of diagnosis after death is WITN 1417001. And this is another family who found out about an infection after their father, in this case, had died. Just turn to paragraph 4 for the outline details. Father had been involved in a motorcycle accident in 1978 and was given a blood transfusion at the French Hospital in Bristol. And he was infected with hepatitis C as a result. Now, paragraph 5, please. We only found out that my father had hepatitis C after he died and after my father's post-mortem. I learned that my father had hepatitis C when I contacted the coroner by telephone to find out why our local funeral directors were treating my father as an infection risk. My father never knew that he was infected with hepatitis C. So, another theme that's been clear, I hope, throughout some of the statements we've looked at is this temporal gap between the date of the transfusion and the timing of communication of diagnoses. It's very common to have sometimes periods that are decades long, and I'll just give you one example, which is a woman who experienced a period of 33 years of delay. She had a transfusion at the Victoria Hospital in Blackpool in 1984. She went for a health checkup with her husband in 2017, and she was told that she was hepatitis C positive in February 1998. She queries why it took such a long time. That example is not unique or unrepresentative, rather the opposite. It's highly representative of lots of people's experiences. If we can just turn up WITN 03 94002, please. WITN 039001. No? Okay.
That must be 394001, surely.
Yeah, sorry, 0394001. Thank you, sir, I'm grateful. So this is the witness statement of the individual I've just been describing. And if we turn to paragraph 7, please, on page 2. Her statement there that I received no information or advice before having the blood transfusion about the risk of being exposed to infection. And then she was infected with hepatitis C, as we can see. And then if we turn up to paragraph 32, penultimate page, please, Sally. This is an expression that many statements repeat, and I'm just going to read it aloud. I want to know why no one ever tried to come and find me, and others like me, to tell me what had happened and offer help. I have lived at the same house and had the same GP and the same local hospital for 33 years, and I've had hepatitis C all that time. So, Sarah, of course, we've got multiple examples of individuals who were contacted through the look-back exercise, and you've heard lots of evidence to date about the look-back processes. But there are others, like this witness, who only found out about their infections because of their own actions, i.e. going to the doctor, having a checkup because they were feeling unwell. The last theme I want to address, Sarah, relates to testing. And you have heard a lot of evidence to date about testing for bloodborne infections, and the evidence for those who've received transfusions and their infected family members is very similar to a lot of the oral evidence we've already heard. But one statement, I think, is a good example. WITN 3324001. This is the affected husband of a woman who received a blood transfusion when she was very young. And if we can turn up paragraph 6, please, Sally, on page 2. There's a description here in relation to how her infection was communicated. She was suffering with abdominal pain in 2018 and was having tests to investigate this. She received some results and was told it wasn't cancer, which was a great relief, as that had been her main concern. However, the advanced nurse practitioner asked to see her, so we thought it was some sort of follow-up appointment. It was for this reason that we didn't think it necessary for me to attend the appointment with her, so she attended alone. Next paragraph, please. I was at work at the time of her appointment and she called me in the afternoon. She told me that she'd been diagnosed with hepatitis C and sounded very shocked. Paragraph 8. My wife and I usually see the same advanced nurse practitioner, and he's very, very good. And I understand that he would not have wanted to scare her. However, I was disappointed that he didn't tell my wife he was testing her for hepatitis C. This meant she had no opportunity to prepare for such a diagnosis. I would also have liked to have been present at the appointment with her, rather than her being alone to receive this diagnosis. So it's just one example, but it fits with a vast majority of statements with witnesses who say they were totally unprepared when they received their diagnosis. So that's the conclusion of this presentation in relation to the experiences of infected individuals and their family members about transfusions. We've got another presentation to follow which relates to the guidance available to clinicians in relation to transfusions. Just looking at the time and whether we should be taking early.
Well, just before you do, you said at the start that this wasn't comprehensive, didn't set out to be. It set out to produce exemplars, I think, of the themes that you identified. Is there possibly a sixth theme? You identified 5 at the start, which is that of those who indicated at the time that they did not want a transfusion, nonetheless having a transfusion given to them against their will or against their wishes, or their wishes being, as they have put it in statements, in some way they're treated as reluctance and overcome in that way. And I have in mind, in particular, 2 testimonies which we've had orally. There are probably others, but this is just from the back of my memory. That of Leslie McAvoy in Leeds,
Yeah.
Who gave a very clear description of how she was deceived, if she is right, and there's no evidence to the contrary at the moment, into receiving 2 units of blood on the basis that the blood had been heat-treated, which we know it could not have been. And the second is that of Jill Fife, who gave evidence in Edinburgh, I think, and who said that she had declined to have a blood transfusion, and nonetheless was given the transfusion. And indeed, that forms, I think, the centrepiece of part of a book which she told me she wrote about her experiences thereafter as a result. Now, they're not the only examples, because I've read a lot of the witness statements, some of which describe a very similar happening to them. So is there possibly a 6th theme? I don't know if your researchers allow you to say.
Yes, sir. And what I would say about that is it's obviously a much smaller group of people that have had the experience that you've just outlined, because it requires...
Or a similar one.
Yeah, because it requires knowledge about the risks posed in transfusions. So some of the examples in the written presentation relate to an individual who asks, in the early 1990s, that blood doesn't have AIDS in it, does it, when they're receiving a transfusion? So it requires a base level of knowledge about the risk of transfusions, and that needs to be contextualised, as we've heard, within the evidence of people not being informed by their treating clinicians about those risks. So absolutely, I remember both of those witnesses that you have raised vividly, and I agree that they would act as their own theme. The problem is that there's so much evidence in front of us, we could probably have a 7th, 8th and 9th theme. But I would agree with you that certainly is apparent on the evidence.
Yes, so if not a theme, at any rate, something to be borne in mind.
Yes, sir.
And it follows also that by those 2 examples that this is a presentation which indicates the lie of the land rather than every detail of the topography.
Absolutely, sir. We simply don't have the time to lay out all of the witness evidence that we've received.
Yes, well, thank you very much. Now, do we want a break before we start with the next? I see.
Yes, I'm
Ms. Fraser
seeing
Butland, who's
some
going to
nodding
present
from
it,
Ms.
I
Fraser
think,
Butland, so yes, that would be
is
helpful.
nodding. So, shall we have a short break? What would you suggest? 5 minutes or 10 minutes?
5 minutes to check some documents.
5 minutes to check some documents, sir.
Very well. 5 minutes it is. We'll come back then at 17 minutes past the hour.